Hello?
Hello. Bear with me just a
Yeah,
moment.
we're having a little bit of technical difficulty right now. We muted everyone, which means that you can hear me.
Training
But
over the
we can't do the call if everyone is doesn't mute their phones because it'll be too loud. So
Okay.
compassionate choice.
Please mute your own phone, and then if you need to speak, just unmute yourself. But we can't. If we mute everyone, you won't be able to hear me.
Mute our phone?
I'm just gonna.
Oh, he looks a little bit like,
I hope folks can bear with us for a second. We're having difficulty if we can't figure out the muting. Amanda, there's no way to mute everybody else but me, right? I mean,
I'm working on it. I'm trying to mute everybody individually. Yes.
All right, babe. Bye. Love you.
Okay. So I'm not going to be able to start until the phones are quiet. So just bear with us for a second. Okay. I think we're good now. Amanda, you can hear me, right?
Yes, we are good to go.
Okay, thank you for your patience, everyone. We just switched to a new conference calling system, and there are pluses and minuses to all the new technology. So thank you for bearing with us. We've got a lot of people on the call, and I'm very excited that people were able to join us tonight. Let me start this presentation. Last year was a very successful year for the New York campaign for medical aid in dying, as well as for compassion and choices in general. You've probably been receiving messages from us, so you know that we had a lot of things happen in the past 6 to 8 months. The California law went into effect in June. Colorado voters approved medical aid in dying as a ballot initiative by a very wide margin, and the DC City Council passed medical aid in dying, and the DC mayor signed the bill. Congress is now in the process, some reactionary members in Congress are in the process of trying to block that law from going into effect, which is the result of DC being controlled by Congress and not having autonomy. And so Compassion and Choices is engaged in work to try to make sure that DC voters have access to medical aid in dying despite attempts in Congress. So you may have received some emails about that from Compassion and Choices, but all of that is giving us tremendous momentum here in New York. For the past few weeks, Amanda and I and the rest of our team have been talking to lawmakers in Albany, and it's just the momentum and the energy is incredible. People are really feeling that this is a serious issue that lawmakers will have to come to terms with this session, and we've got a lot of work ahead of us. So the reason that we wanted to do this training now is because while many of you have been involved in our efforts in the past, we wanted to sort of establish a baseline. And now is the right time because the Medical Aid in Dying Act is being reintroduced for the 2017 legislative session. There are some slight but important changes to the bill, and we wanted to make sure that everyone had a sufficient understanding of compassion and choices, of the way that we speak about medical aid in dying, the New York bill, and what our campaign entails. So I really appreciate those of you who've been with us from the start and have heard many of these things many times. I appreciate you joining in today. Everyone will have this baseline knowledge. I am going to turn it over to our outreach manager, Amanda Kavanaugh, and Amanda's going to take it from here, and she and I will go back and forth and stop from time to time to ask if there are questions. You probably will have questions along the way, but it's likely that we're going to get to your question in a future slide. So have a little bit of patience, but we'll stop from time to time to open the lines up. Okay, Amanda, you wanna take it from here for a little while?
Sure. Are you going to share your screen? Corinne, can you just open up your screen to show the PowerPoint?
Oh, my screen is open. My screen is open.
Okay.
So you're not seeing the timing either?
No.
Oh no. Can you make yourself the presenter?
I can. I will do that right now.
Thanks, folks, for your patience again. Apologies for this.
Sorry, bear with me just a moment.
I just got to show my screen invitation. So can you see me now?
I do. It just says
Okay, can you see me now?
yeah, I can. So thank you again, as Curtin mentioned, for joining us this evening. I'm just going to ask Bonnie. I'm just going to pick on you because I see you're on the call. Do you see Corinne's screen? Okay, I just unmuted you.
Yes, I see it. I see it now.
Okay, perfect. Thank you. So thank you all for joining us. As Corinne said, we really appreciate you being here tonight to hear about what's happening with our campaign and how to get involved. Tonight's training, we are going to go over things that you may or may not have heard of before. Who is Compassion and Choices? What is medical aid in dying? What does the New York Medical Aid in Dying Act do? And what is the status of the legislation? Who supports aid in dying, and what are the objections of those who don't? What is our message? How do we answer frequently asked questions? And where do supporters fit in? So who is Compassion and Choices? Compassion and Choices is the nation's oldest, largest, and most active non-for-profit organization committed to improving care and expanding choice at the end of life. Our vision is a society where people receive state-of-the-art care and a full range of choices for dying in comfort, dignity, and control. We aim to ensure individuals understand the risks and rewards of all feasible treatment options, treatment decisions are fully respected, and that the care reflects a person's values and priorities for life's final chapter. So by providing information, we are a national non-for-profit organization, as I said. We are on the ground in 16 states. We are the largest and most active. Our New York campaign was officially launched in September of 2015. In New York State, we support the legislation that would authorize medical aid in dying. And we organize grassroots supporters. We work with doctors and faith leaders across the state, and we lobby lawmakers in Albany. Some of the services that Compassion and Choices provide: we defend physicians who aggressively treat pain. We take legal action on behalf of families. Public education, including end-of-life planning. Assistance in preparing advance directives. Support for families from beginning to end of the terminal diagnosis. Legislative activities to improve laws, lobbying efforts in district meetings, and so on. We have client and family services, so our end-of-life consultation program, and a doc-to-doc peer discussion on end-of-life procedures. One of the things people often think is that we say we do all of these things, but what does Compassion and Choices really do? And I think one of our more important things Compassion and Choices has done is help for end-of-life discussions to be reimbursed by Medicare. So previous to this law being in effect, doctors were not having end-of-life discussions with their patients because they weren't being paid for them. Compassion and Choices was really instrumental in making sure that doctors would get reimbursed for this service so that they would have these discussions with people. So that is one thing that Compassion and Choices has done on the federal level, and that's just one example of the work that we do.
Amanda, I think I'm going to take over because there's a lot of background noise for you. So I'm going to mute my computer so there's no beeping, and I'm just going to take over. Is that okay?
Okay.
Okay. So as Amanda said, we have an end-of-life consultation program where we serve terminally ill adults from the time of their diagnosis, helping them to make sure that their own end-of-life care wishes are honored according to their own beliefs and values. We have a 24-hour hotline for families, but I want to warn you, we've got limited capacity and now a tremendous demand for these services, given how much Compassion and Choices has been in the news. And so if you refer folks to this, Amanda, do you think you could mute your line as well? If you refer people to this 24-hour hotline, you should know that at this point, they'll be leaving a message and one of our professionals will get back to people. So that's important for you to know if you're giving anyone this 24-hour hotline. We also, one of the other things that we do at CNC is we educate people. We engage in a lot of community outreach and provide materials on end-of-life planning. We provide advanced planning resources to people. We encourage and we train people to tell their own stories about end-of-life care. We meet with community leaders. We train volunteers like we're doing tonight. And we share news and information about the movement to authorize medical aid in dying and to improve end-of-life care online through Facebook and our webpage. An important part of our job is to advocate for changing laws and making them better. Toward that end, we provide legislative testimony and engage in advocacy like meeting with lawmakers. We engage in litigation on high-profile cases to establish rights for people who are terminally ill. We help to author laws and to bring initiatives both at the local, state, and federal level. We engage in community organizing. Amanda and I have traveled from Buffalo to Long Island and the North Country to Brooklyn and everywhere in between, talking to various communities. Let's work on that muting thing if there's any way to do that. It's going to be tough to keep stopping the call. And we also engage in local, state, and national strategies, like getting city councils or town boards to pass resolutions in favor of medical aid in dying. We get a lot of questions about our funding. One of the allegations that our opponents make is that our funding comes from insurance companies or from the government sometimes. And you can see here from the chart that 95% of our funding comes from individual contributions, which is really astounding for a nonprofit organization. We spend the vast majority of our funding on programs, and we've received the highest rating for nonprofits from Charity Watch and Charity Navigator. As Amanda said, we're on the ground in 19 states, and you can see here where we have active campaigns going on. Of course, in Oregon and California, Colorado, those are states where we still have staff on the ground helping to implement the laws that have been passed there. These are the states where aid in dying is authorized. As you know, Oregon was authorized medical aid in dying by ballot initiative in 1994. Washington followed in 2008, also by ballot initiative. Montana, residents of Montana got access to medical aid in dying through a court ruling in 2008. In Vermont, the state legislature passed the bill in 2013. It was the first legislature to do so. And then in California, they passed the law in 2015. It was signed into law in October and went into effect in June of this past year. And just recently, Colorado voters passed the measure by ballot initiative into just this past November. In Washington, D.C., medical aid in dying would be authorized, but for Congress's attempt to block because it was passed by the City Council in November and then signed by the mayor. And then in New Jersey, just so you know, the bill passed the Assembly in October, and it actually did move to the Senate. The slide hasn't been updated. It was passed by the Senate, but the governor in that state actually has blocked the law. So New Jersey, the legislature has moved on this initiative, but the governor has blocked it. So what are we talking about anyway? What is medical aid in dying, and why do we need this option? As most of you know, medical aid in dying is a safe and trusted medical practice in which a terminally ill, mentally capable person who has a prognosis of 6 months or less to live has the option to request from their doctor a prescription for medication which he or she can use to self-ingest to end unbearable suffering and to die peacefully. The medical practice is also known sometimes as death with dignity, and we'll talk about that terminology a little bit further along. Amanda, there's at least one line that's not muted, so maybe you can help figure that out. So why do we need medical aid in dying? As most of you know, the options for end-of-life care that exist right now are obviously the right to aggressively pursue life-sustaining treatment. People have the absolute right to refuse treatment or to discontinue it. They can enter hospice if they've received a 6-month prognosis. They can voluntarily stop eating and drinking, which is often referred to as BSED. They can opt for palliative sedation, which means that an amount of pain-relieving drugs can be administered to someone so that they're placed into a medical coma until they no longer receive nutrition and hydration and die. Medical aid in dying is along the continuum of end-of-life options that people should have. Each of these options is right for some and not for others, and that's the message that we want to keep giving, is that these are just options that everyone should have. So who is eligible for aid in dying? Aid in dying is not widely used or requested in the states that authorize it. To receive an aid in dying prescription from the doctor, someone must be over 18, in the final stages of a terminal illness as confirmed by a second opinion, of sound mind, and they must take the medicine by themselves. They must be able to self-administer it. So what if someone changes their mind? About a third of people who receive a prescription for aid in dying medication choose not to take the medication at all. But having it on hand provides them with peace of mind, knowing that they can end their pain and suffering should they become too great. I'm going to spend a moment talking about New York's legislation, the Medical Aid in Dying Act. The bill was introduced last year. You may recall that there were several bills in the legislature in 2014, and those versions were combined into one, the Medical Aid in Dying Act. Does the sound?
Yeah, Corinne, everybody's muted, so I'm not sure if...
Are you muted?
Yes.
Are you muted?
Yep.
Okay. Yeah, I'm not sure what the problem is. I hope people can hear. So the bill was introduced on May 10th, 2016. It's sponsored by Senator Diane Savino and Assemblymember Amy Paulin. It passed the Assembly Health Committee on May 23rd, 2016, and it is going to be reintroduced imminently. I checked about an hour ago and the bill was not up, but we received word that the bill should be available publicly probably by tomorrow morning, and we'll have new bill numbers for folks soon. We are having a kickoff press conference on Monday here in Albany at 1 p.m. with the sponsors of the bill, and by that time we'll have new fact sheets with the bill numbers and the summary of the changes then. But I'm going to give you a little bit of a preview of the bill and the summary. For those of you who've been working on this, much of this is going to sound very familiar, and it tracks the general definition of medical aid in dying. The legislation would allow a terminally ill, mentally capable adult to request life-ending medication from a doctor that the person can take at a time of his or her choosing or never to bring about death, so long as he or she can self-administer it. The safeguards in the bill mirror those that have been in place in Oregon, Washington, Vermont, and now in California, that the terminal illness be confirmed by 2 doctors, that there are 2 witnesses to the written request, there are penalties for fraud and coercion, there are referrals to counseling if doctors believe that the patient lacks capacity to provide informed consent. The law requires that a person must be counseled on all feasible treatment options, including pain management, hospice, and palliative care. Neither age nor disability by themselves qualify. You must be terminally ill. Any unused medication has to be disposed of according to health department guidelines. The cause of death is listed as the underlying illness or disease. Immunity from civil and criminal penalties and professional malpractice are provided for in the law. The law says that if anyone alters, destroys, conceals, or forges a person's request, commits a felony. Insurance companies cannot deny payment on an annuity or a life insurance policy. And significantly, no physician is required to participate if they don't believe in the law. Now, there are some important changes to the 2017 bill. Most of those changes simply reorganize language for the sake of clarity, but there are 2 substantive changes that reflect feedback that the sponsors received from community stakeholders as we've been holding meetings across the state over the past 8 months. The bill clarifies the definition of capacity to request medical aid in dying to make sure that a terminally ill person must be able to communicate his or her request to a physician directly. The other substantive change is that in the case of a physician who refers a patient to a mental health professional for a determination of capacity, the report from that mental health professional has to be delivered to both the attending and the consulting physician, regardless of who made the referral. The old bill would have had the mental health assessment going only to the requesting physician and not to the other one. I'm going to stop here and see if there's anyone who has a question, because I've gone over a lot of material. And yeah, that's the New York bill. So do we have any questions, Amanda?
I don't see, if anybody has any questions, there's a chat box on the bottom of your screen. You can type it in there and I'll be able to see it and answer them for you. So I'll just take a second to see if anybody has any.
Amanda, can you hear me?
I can.
Okay, I was not able to access the screen.
Okay, I'm going to send out a copy.
So
Yep, we'll send out a copy of the presentation once it's over.
Okay, great. Thank you.
Thank you.
I'll go back to mute.
Thank you. Corinne, as far as there's a question, the communication part that's been changed, is it in writing or verbally?
The bill already said that the request has to be made orally, followed up by a written request for the medication. What this change does is it removes a strange clause that was in the old bill that said that someone could communicate through someone who is familiar with their means of communication. And folks in the disability rights community and people who were concerned about autonomy were worried that that would mean that someone else would have control over someone's decision. That clause was removed to ensure that we're really talking about patient autonomy, and a person has to be able to clearly express orally and then in writing their wish for medical aid in dying. Any other questions, Amanda?
I don't see any other questions, but what I have been hearing from folks is that some people just called in. They didn't actually log in on the computer. So if you're somebody that only called in, I don't have the ability to mute you. So please mute your phone.
Aha. Okay. That's helpful. Okay, I'm gonna go on. Oh, we have another question?
We do. If a person cannot talk or cannot write, are they not able to request aid?
The bill is every law that passes in New York is subject to federal and state civil rights laws. And so for folks that are unable to verbally communicate or communicate in writing, there are other areas of the law that allow them to express their wishes. It just has to be absolutely clear that it's theirs. So for example, there needs to be a certified translator if someone is speaking in sign language or speaking another language. And laws that govern consent would allow someone to make a mark if they can be assured through witnesses that that is their mark. So if someone is unable to speak, they're able to express their wishes in other ways. The changes to this bill just make sure that it protects the idea that the doctor and everyone else that is involved know that the request is coming from the patient and not being interpreted by someone else who's not a certified interpreter. Any other questions?
No, I think we're good to go. Okay.
So let's turn our attention now to who supports aid in dying and what are the objections of those who don't. You may remember that we did polling last year in September. It was a poll of 1,000 registered voters across the state. And what we found is that from the very first question, 77% of New Yorkers said that they supported the notion that people should have the ability to ask for aid in dying. When we told them more about the law, what the safeguards were, and some of the arguments against the law, we found that support grew to 81%. So what we learned from that polling is that the more we talk about this issue and answer questions, the greater the support. The other interesting thing about the poll is that support held steady from the cities to the suburbs to the rural areas, from upstate to downstate, across parties and across religious affiliations. Those numbers held relatively steady. And we'll talk about support among people of faith a little bit later. But what are the objections? If there's such widespread acceptance of the idea of people being able to choose medical aid in dying, what about those folks who object? What are their arguments? And there are generally, they fall into three buckets. One, faith-based objections. Two, objections based on the belief that doctors don't support medical aid in dying. And three, objections based on fear of misuse, coercion, and a slippery slope. Let's start first and talk about some of the faith-based objections. I should note, and as I said with regard to the survey that was done last year, 74.8% of voters who identified as Catholic support aid in dying. And even among those who attend church weekly and more than once a week, that number was still 61%. We've been engaging in a robust effort to recruit faith leaders to sign on to a letter of support to lawmakers. And at this point, we have well over 24 diverse faith leaders from across the state that have signed on to our letter. And there are prominent faith leaders who have stepped out and said that they believe in aid in dying. You may actually have seen Archbishop Desmond Tutu's Washington Post opinion piece on his 85th birthday. He now, after many years of thinking about this issue, has come out in support of medical aid in dying. Dr. Paul Smith, who is a Presbyterian minister and civil rights advocate from Brooklyn, has said aid in dying isn't about death. It's about how we spend our final days of life. Everyone deserves a dignified death, no matter what end-of-life option they choose. And in fact, Governor Jerry Brown, who was trained as a Jesuit priest, in signing the California bill into law, this is what he said in his very clear signing statement. He said, "In the end, I was left to reflect on what I would want in the face of my own death. I don't know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I wouldn't deny that right to others." So what we're finding is that many people of faith are echoing the sentiments of California Governor Jerry Brown by saying, I don't know what I would do, but I wouldn't deny the right to others to make choices that are consistent with their own faith and beliefs. And quite possibly, George Carlin has said it best: religion is like a pair of shoes. Find one that fits for you, but don't make me wear your shoes. That what we're finding is that New Yorkers really believe that religious freedom means that everyone can make their own end-of-life decisions that are consistent with their own faith. And for people who don't believe that medical aid in dying is supported by their faith beliefs, they would never make the request. There are objections based on the belief that doctors don't support medical aid in dying. So we should look at what doctors actually think. Medscape has been doing a survey of 17,000 physicians since 2010, and what they've asked this question: patients with an incurable and terminal disease should have the option to choose death with dignity, also known as the medical practice of aid in dying. And in 2010, support among physicians was 46%. That grew in 2014, and the latest numbers that came out in December show that 57% of physicians believe that individuals should have the right to medical aid in dying. What I find much more interesting is this number, and I'm going to go back one, the number that has held steady around 14 and 15% every year who say that it depends. Well, it absolutely depends, and that is what the Medical Aid in Dying Act does. It's not medical aid in dying upon request for everyone. There are careful eligibility requirements and safeguards, and I believe that that's what falls under it depends, because of course it depends. So if you consider those numbers, the vast majority of physicians now support medical aid in dying. But it is true that there's still official opposition. The American Medical Association maintains a position against medical aid in dying, as does the Medical Society of the State of New York and the Hospice and Palliative Care Association. But we're seeing a lot of changes here. Professional associations of healthcare professionals now support medical aid in dying. The American Public Health Association, the American Medical Students, the American Medical Women's Association, the American College of Legal Medicine, the National Association of Social Workers, the Denver, Boulder, and Colorado Medical Associations, the New Mexico Hospice and Palliative Care Association. California's Medical Association, when it shifted its position from opposition to neutral, really was the key in passing California's law. And what they said at the time is that despite the remarkable medical breakthroughs we've made and the world-class hospice and palliative care we can provide, it isn't always enough. The decision to participate in the End-of-Life Option Act is a very personal one between a doctor and their patient, which is why CMA has removed policy that outright objects to physicians aiding terminally ill patients in end-of-life options. And many medical associations and healthcare groups are following California's lead and increasingly taking a neutral position. So the American Academy of Hospice and Palliative Medicine, the New York State Academy of Family Physicians voted in June to follow the DMA. The Colorado Medical Society, the American Pharmacists Association, the American Psychological Association, the American Society of Health System Pharmacists, the Oncology Nursing Society, the Older Women's League, Hospice and Palliative Care Associations in California, Missouri, and Vermont. And we're actively seeking those shifts here in New York as well. Some of the physicians that we work with are presenting to their local medical associations, and we're finding an overwhelming amount of support among doctors regionally. Our work is to prompt those county medical societies to get the Medical Society of New York to reconsider its opposition to medical aid in dying. Just like the American Medical Association is doing. The AMA decided this past summer to re-examine its position on aid in dying, and many of us have been involved in the work to shift their thinking and influence the decision that they ultimately make, considering all of the evidence that's been in place for over 2 decades. I'm going to stop here and see if anyone has questions, and then we'll move on to the final objection. Okay, if there are no questions, let's turn our attention to objections based on fear of misuse, coercion, and a slippery slope. We often hear the argument that authorizing medical aid in dying would put vulnerable populations at risk. What we know from a combined state's 30-plus years of experience with aid in dying laws is that there has been no abuse or coercion found in any of those states that authorize medical aid in dying. In fact, the leading disability rights organization in Oregon, which is aptly named Disability Rights Oregon, has never received a complaint that a person with a disability was coerced to make use of its Death with Dignity law in the now nearly 20 years that the law has been in effect. And the evidence from Oregon is clear. Since the bill passed and went into effect in 1997, just over 1,500 people have received the prescription, and only 991 have ever taken the medication. That means that over a third of the people who received the prescription haven't taken it. Many of those people have died natural deaths, and their families have reported that it gave their loved ones peace of mind to know that there was another option. Of the deaths that occurred in 2015, the latest year for which the data is available, over 90% of people were able to die in their own homes. 92% of them were enrolled in hospice at the time that they used the prescription. And in 95.5% of all of the cases, families had been notified and were an integral part of the individual's decision and their death. And end-of-life care has improved in Oregon since the law has gone into effect. There's been a 30% increase in referrals to hospice. Close to 70% of doctors took continuing education classes to improve end-of-life care. 70% were more willing to increase morphine dosages to control pain. And 3/4 of those doctors felt better equipped at pain management after receiving training. It's important to note that in the years that the Oregon law has been in place, there has been no attempt to amend, fix, or expand medical aid in dying. Usually with a new law, a law that breaks ground, there needs to be some tweaking along the way to fix imperfections. And that's not been the case in Oregon. Now, we've learned a lot from the Oregon experience, and that's why there have been tweaks here and there to each subsequent bill that's passed, and I think the New York bill combines the best of what we know from all over. But it's important to note that those original principles of patient autonomy that require a prognosis of 6 months or less, that require the terminal diagnosis confirmed by 2 doctors, the assurance of capacity and informed consent, none of those things have been changed to expand them to include more categories of people who may be suffering. So this notion that we're going to move to a European model, for example, that allows more than just terminally ill people to request medical aid in dying is a fallacy. We have a model in this country. It's the Oregon model, and it's worked. And that's why we've borrowed from that experience in the Medical Aid in Dying Act here in New York. One thing we know about medical aid in dying is that it improves end-of-life care for everyone across the board. Every year, the Center to Advance Palliative Care releases a report card about how states are doing in terms of access to palliative care. And in those states where aid in dying is authorized, they generally get an A on the scaling system that this group has adopted. New York got 78.1 out of 100 points on this scale, and so the Center to Advance Palliative Care gave New York a B. Personally, I think we deserve a C. I was a teacher, 78% is a C, but at any rate, I think that New York can do better, and that's why we need the Medical Aid in Dying Act. I think our care will get better once we expand opportunities for people to have conversations about what their end-of-life care should be. People living with disabilities have also been some of our opponents. Not all people living with disabilities oppose medical aid in dying. In fact, there are some limited polls out there from 2001 and 2014 that show that people living with disabilities often support medical aid in dying laws in the same percentages as the general voting population. So there really is no unanimity of opinion. And there's increasing support among people living with disabilities. The Disability Rights Legal Center and the Legislative Coalition for People with Disabilities in Utah support medical aid in dying laws. Here in New York, we've been doing a tremendous amount of work with people living with disabilities, and there was a community conversation that was held in Utica at the Resource Center for Independent Living. Compassion and Choices supported that effort. We participated. Dr. David Pratt, who's our physician advisor, and I both spoke at that forum along with people who opposed the law. Senator Diane Savino was there as sponsor of the bill. And after the conference, Jean Hughes, who works at the Resource Center for Independent Living, wrote a great opinion piece in the Utica Observer Dispatch, which was published on November 15th. And what he said is, "My life value can't be diminished by aid in dying. To the contrary, my life would be empowered by medical aid in dying. It would give me the autonomy I've worked so hard to maintain since my very first day in a wheelchair. Medical aid in dying is not a disability issue, it's a human issue. Questions are fair and understandable, but let's look at the facts rather than misinformation and fear. A disability or a chronic condition alone is clearly not a terminal illness and therefore doesn't qualify under the legislation. Every New Yorker facing the end of life should have the right to decide when suffering becomes unbearable. This is equally true for those of us living with disabilities." So I think we're seeing some shifts in that community. I think we have to recognize that there are real fears that people have in the disability rights community about mistreatment they've received at the hands of healthcare professionals. But what's becoming clearer and clearer is that medical aid in dying laws are about patient autonomy, and this is consistent with the goals of that community.
Correct.
So let's talk about, yes.
We just have a question. So folks have asked if we're concerned with insurance companies denying treatment options due to the cost, but then suggest an aid in dying as an alternative. Does this happen, and is it even ethical?
Yes, that's a very good question. As I think everyone who's on this phone call understands, we really do have a broken healthcare payment system. I think, opponents of reform and, supporters of reform all agree that we really need to fix our payment system. Medical aid in dying laws don't make those systems better or worse. You may have heard some stories out of Oregon about people who got letters denying experimental treatment or advanced treatment that was deemed not to be likely to be effective, and then at the same time being offered medical aid in dying, which would be paid for by the insurance company. To be clear, the New York legislation forbids an insurance company from denying treatment that they would normally cover and offering medical aid in dying coverage at the same time. People will still, until we get around to fixing our healthcare payment system, feel that they are unjustly denied access to different kinds of treatment, and that happens for a whole host of reasons, much of it having to do with the profit motive of insurance companies. Medical aid in dying, at least the way that the law is written now in the states that have recently adopted it, has nothing to do with that, and insurance companies can't deny at the same time as they offer coverage for medical aid in dying. I hope that answers the question. Are there any other questions, Amanda?
Nope, that was it.
You know, I should make one more comment on that, because one of the things that you may hear is that there is a California woman who received a denial of treatment and an offer to pay for medical aid in dying. And what we need to know about that story out of California is that you can't be given a decision on coverage for medical aid in dying unless you ask for it. So no one can be offered medical aid in dying. One has to affirmatively ask. And that person, whose story is told by our opponents, has been a long-time opponent of medical aid in dying laws, and she affirmatively requested medical aid in dying, and that's why she got a letter in the mail offering her coverage for it. So it's important to contextualize the stories that are being told by our opponents. All right, I'm going to move on and talk a little bit about language. There are a lot of words that we use around medical aid in dying, some shorthand that people have used in the past. And the words that we use are really important. And one of the words that I want to talk about is the word dignity. As all of you know, the law that was originally passed in Oregon was called the Death with Dignity Law. This movement has been known as the Death with Dignity movement, and many of our partner organizations use that phraseology in their title. But what we've heard from both opponents and supporters is that there are many ways to die with dignity. And when you call a medical aid in dying act or bill a death with dignity law, it presumes that the only way to die a dignified death is by using medical aid in dying. That suffering with those other options that I mentioned before is not dignified. And I think that the experiences that many of us have had with loved ones who have died really belie that conclusion, that there are many ways to die with dignity, but the key to dying with dignity is that you are able to die the way that you want to, whether that's at home or being cared for in a hospital, whether that's, after being sedated, or refusing life-sustaining treatment or nutrition and hydration. Dignity is all about the way that someone defines the way that they want to die. So there are a number of key messages that we use when we're talking to lawmakers, and generally we tailor our message to our audience. But these are, I'm going to just read off 6 of the key messages that we've used in our campaign. The first is that every New Yorker should be able to make end-of-life decisions that are consistent with their own faith and values. The second is that we should have the right to learn about all of the options at the end of life that will help us have the kind of death we want, and we should have the right to decide which option is best for us. The third is that medical aid in dying is one of several end-of-life options that should be available to people who are dying, including access to hospice and quality palliative care. Another really echoes Governor Brown's signing statement in saying, I may not decide to utilize aid in dying at the end of my life, but it would give me peace of mind to know that I have the option to do so. Another is, while hospice and palliative care can help most people most of the time, for some it's not enough, and for them aid in dying should be an option. And the last is, when the Medical Aid in Dying Act becomes law in New York, no patient can be forced to use it, and no physician can be compelled to participate. If you come to any one of our events or our lobby day, we will have those key messages available to you. And when Amanda sends you the PowerPoint after this training, you'll be able to review these on your own. It's important to distinguish between things that our opponents call medical aid in dying. And one of them is euthanasia. And it's important to note that euthanasia is the ending of a person's life by a third party, usually a physician, and most often it's by lethal injection. The proposed bill here in New York prohibits euthanasia, which is illegal everywhere in the U.S., including those states that have authorized medical aid in dying. Aid in dying is also not mercy killing. Mercy killing is the ending of a person's life at the request of someone other than the patient. The proposed bill prohibits mercy killing, which is illegal everywhere in the U.S. It's also not suicide. Suicide, which is not against the law anywhere in the U.S., is about choosing death over life, and it's often motivated by an underlying illness or condition like depression, which can be treated, thus allowing the person to live a full life. When someone has been diagnosed with a terminal illness, they are by definition actively dying, and so no longer have a choice of death over life, but they may want the choice of one form of death over another. And I will add that when our opponents talk about medical aid in dying as suicide, or when our supporters say that this is just rhetorical and that we should embrace the use of the term suicide, which some of our supporters have said in the past, we need to understand the harmful effect that that has on families whose loved ones have chosen medical aid in dying, or for people who are terminally ill and considering this as an option. Suicide really means choosing death over life, and all of our supporters love life and they want to continue living. They just want a choice over what their final days look like. So I think this distinction is more than rhetorical, and it's important to keep it in mind.
Corinne, just one question. When you're talking about opt-out, does that apply to all licensed health professionals besides physicians, or is that only for physicians?
The bill itself makes explicit that the opt-out provision applies to physicians, that physicians who have an objection to medical aid in dying can refuse to participate, but existing New York law which already has conscience clause protections, would allow pharmacists to object. The closest parallel is dispensing contraception, and this issue has been handled in the courts. And basically, the basic gist of the law in New York is that a pharmacist can't refuse care if there's no other option available. So, existing law would cover pharmacists, but there would probably be some regulations developed to handle those situations. Are there any other questions?
Nope, that was it.
All right, so let's turn to some frequently asked questions. We've certainly covered some of the things that we've heard as objections, but there are some concrete questions that it would be helpful for us to know what the answers are. And so I'm going to go over those right now. Just give me 1 second. So one question that we often get is, how do medical aid and dying laws differ from the different states that have adopted it? And medical aid and dying laws in statute, Oregon, Washington, California, and Vermont, are all similar and based on Oregon's law. Each has core protections in place to ensure that the laws work as intended. For example, the core safeguards in all of those states include that anyone seeking medical aid in dying must be terminally ill and mentally capable. They must make the request on their own behalf. They may withdraw their request or decide not to use the medication, and they must be able to self-administer the medication. There are some differences in the form of the request. Some states require a waiting period between the first oral request and the second. Some states have different requirements about who can witness the request, but those 4 core protections exist in each one of these states. The next question is, does New York, and this is actually the most frequent question we get everywhere we go, does New York still allow people with Alzheimer's and or dementia to access medical aid in dying? And the answer is no. None of the states that authorize aid in dying allow people who can't consent at the time that they want to take the medication to empower someone else to make the decision for them, for example, as a healthcare proxy, or to specify that they want aid in dying in a living will. So the question becomes, does Compassion and Choices support the idea that medical aid in dying should be available? The fact is, we recognize that severe dementia is a difficult issue facing many older adults, and we're committed to improving the dying process for people with Alzheimer's and dementia. One of Compassion and Choice's core values is that the dying person must be in charge of their death. Given this, we don't advocate for medical aid in dying to be expanded to people with Alzheimer's because they're not mentally capable of making healthcare decisions for themselves at that time. We are, however, committed to improving care, and as an example, we pioneered the creation of what's called the dementia provision that can be added to Advance Healthcare directives to provide some additional options if this terrible condition strikes you or a loved one. It can be found on CNC's website on the End of Life Information Center page. And we also support federal legislation that aims to improve the lives of people with Alzheimer's. And that bill is called the Health Outcomes Planning and Education for Alzheimer's Act. And the acronym is the HOPE Act. Just want to make one note on the dementia provision. We were doing a training here in the Capital Region, and after explaining the answer to this question, a woman stood up and told the story of her mother who had been admitted to the hospital for a medical issue. The mother had dementia, and she developed an infection in the hospital. And the doctor sat down with the daughter, who was our audience member, and explained that her mother had included in her living will a dementia provision. The doctor asked the woman if she knew what that meant, and she didn't. She'd never heard of it before. But what the doctor said is that her mother put this in her living will so that if anything happened to her when she had dementia, that she was opting for no treatment. And the doctor explained that would mean that left untreated, the infection would likely take her mother's life within the week. The daughter thought about it for a moment, and she told us at this presentation that it was like her mother had given her a gift. She knew that her mother didn't want to live for years and years with dementia, and by putting in place this dementia provision, it allowed her to pass quickly after getting this infection. That's certainly not what everyone would want, but it is one way to deal with dementia and Alzheimer's. And for more information, you can check our website.
Corinne, we have a few questions. The first one is, are DOs, physician's assistants, and nurse practitioners authorized? And then what about DOs?
So physicians are the only ones authorized to prescribe medical aid in dying under the New York Medical Aid in Dying Act. Physician's assistants are not authorized. Only licensed physicians in New York.
Okay, the next question is, many large medical medical organizations have been bought by the Catholic organizations. How do we ensure that patients have choice in these situations with the opt-out clauses? Do they pertain to whole organizations?
Oh, it's a very good question, and they do apply to whole organizations. We've had a tremendous amount of success in California at discouraging Catholic hospitals from opting out of California's End-of-Life Option Act. There are recent stories out of Colorado suggesting that the opposite is true in that state. Colorado's law was just passed in November. We have a robust campaign spearheaded by Compassion and Choices on the ground there, and I have no doubt that we'll make the same kind of progress in Colorado as discouraging Catholic hospitals from opting out as we have in California. But it's certainly a concern that we have because there are, I think in New York more than in any other state, there are hospital systems that are owned by Catholic Health Services. So it's a good question. It's a concerning one. But our job after the bill is passed is going to be to ensure access for New Yorkers. And so we'll be kept busy making sure that that's done.
The next question is, how is the dementia provision different from the Alzheimer's disease and dementia mental health advance directive out of Washington State?
I can't answer that on this call. We can have a conversation offline, but I don't think I can do the question justice in a training like this to describe the differences. So I would encourage the questioner to contact us offline.
Okay. For mental health professionals who are not licensed physicians, such as psychologists, clinical social workers, how would opt-out apply with regard to capacity determination?
Well, if a doctor referred to a mental health professional, the mental health professional, if they didn't believe in aid in dying, just wouldn't accept the referral.
Okay, and then is a DO the same as an MD where aid in dying is concerned?
Knew that question was coming, and you stumped me on that one. I should know the answer, and I have to confess that I don't. So I'm going to have to get back to the questioner on that one.
Okay.
Can I butt in? Can you hear me? Hello?
We can hear you.
Yeah.
Okay.
We were able to hear you.
Okay, I'm back on. A DO is has the same privileges as an MD in New York State, I believe.
Right.
That would have been my guess, but because I didn't want to guess, I didn't want to say that. That may well be true. You could be 100% right, but I didn't want to guess. In general, that's my understanding of New York law, but I'd like to firm up the answer before I give it.
Okay, but DOs can do anything an MD can do. The only difference is that they have a slightly different orientation in terms of, I think, the skeletal structure of the body, but they meet the New York medical requirements, and they take the same exams to be certified.
I appreciate that, and I hope that what you'll do is appreciate my honesty. As a lawyer,
I do. I'm just contributing because I have used DOs, and I know one personally, and I've never gotten the impression that there was anything that barred her from doing anything an MD could do.
If I were a betting person, I'd be with you, but as a lawyer,
okay.
I want to reserve the right to confirm it. So
right.
I will
right.
be back in touch and let folks know. Thank you.
Okay, I'm going back on mute.
Thank you.
All right, Corinne, you are set to keep going.
Okay. So the next question that we get is, what medication is used in medical aid in dying? And prescriptions for medical aid in dying typically involve 3 separate medications: a drug to speed absorption and prevent nausea, followed by a short-acting barbiturate. Capsules of the protocol medication are broken open, and the contents are mixed in water or some other liquid. Patients drink that liquid and then normally fall asleep within 5 to 20 minutes. Respiration slows and then it stops, and families report that it is a peaceful death. What I think I want to note here is that medical aid in dying is becoming such a recognized, legitimate form of care that the Journal of Palliative Medicine published clinical criteria for medical aid in dying. You may note that the Medical Aid in Dying Act doesn't specify what drug can be used, and that is the right approach for any legislation because drug prices change, different drugs are developed, and we learn more and more every single day about what things work. But this is the protocol that is in place now. The most commonly used medication is called secobarbital or Seconal, and when broken up, from 100 capsules and mixed in the liquid, it's a very bitter tasting liquid, and so people who use medical aid in dying are encouraged to drink it quickly, because if they drink it slowly, they could become drowsy and not get the full dose. So, all of these things sort of operate in a way that assure patient autonomy. In other words, you have to really be sure that this is something that you want to do, to go through taking 3 different kinds of medication and drinking the very bitter liquid. And it also helps, as we're going to tell in a moment, in making sure that it's not accidentally ingested. Which is really the next question. What if the medication gets in the wrong hands or is abused? And what I can tell you is that in the combined 30 years of experience across 4 states, there has never been an accidental overdose of aid in dying medication. What we do know is that we send people home on hospice and palliative care and from dental appointments with far more dangerous medicine that can be accidentally ingested. Because the medication requires such a high dosage, it's not easily used accidentally. It's bitter, as I said, and a person, if they hadn't taken the preparatory medication, is likely to regurgitate it if they don't take something to suppress the vomiting. One is more likely to overdose on common over-the-counter medications or the many potentially lethal medications prescribed at the end of life, such as morphine. Another question that we have is, aren't other options good enough, like palliative treatment? Shouldn't we be focusing our attention on improving hospice and palliative care before we look into medical aid in dying? And the fact is, medical aid in dying falls in a continuum of palliative care. About 90% of people who use medical aid in dying in Oregon are enrolled in hospice, the gold standard of palliative care. Other options that advance the time of death, like stopping eating and drinking or palliative sedation, are also in the palliative care continuum and the best option for some people. For others, terminal palliative sedation does not relieve extreme pain and suffering, which can substantially impact the quality of life during the person's last days or months. When a person only has months or weeks or even days to live, when medical treatments can't extend life or relieve unbearable suffering, we should allow people the option to shorten the prolonged dying process. And at this point, I just want to tell you about someone special to the New York campaign. His name was Jay Callio. Some of you may have met him. He volunteered with us at the state fair this past summer, and he passed away a few months ago. We were doing a video project with him so that he could explain why he's such a strong supporter of medical aid in dying, and he described a death that he feared, and that was a death where he would be screaming in pain and where no one around him could help relieve his suffering. And I have to tell you, I visited Jay in the hospital at Beth Israel in New York City when in his last hospitalization, and his partner recalls the last 22 hours of his life as being exactly as he had feared. He was in a premier medical establishment in the heart of New York City, some would say the capital of modern medicine, and they could not find a way to relieve his pain. And so if you hear passion in my voice and see the work that we've done in our campaign, it's really for people like Jay, who died the exact death that he feared. So the notion that providers can relieve pain with the best palliative care, with the best resources, is just a fallacy. So there are problems with palliative sedation. Many people say that they want to die at home, and 94% of palliative sedation has to be rendered outside of the patient's home. Many people have multiple symptoms such as pain, nausea, shortness of breath, and not all of these can be alleviated by palliative sedation. Patients may want to be able to communicate with their loved ones at the end of their lives, and palliative sedation makes that impossible. One fear that people have is that people who are undergoing palliative sedation may look comfortable, but this may be the result of paralysis and not of sedation at all. Some studies have shown that a significant percentage of people don't achieve adequate pain and or symptom relief from palliative sedation. And you may ask, well, how would we know that palliative sedation is used at the end of life? In fact, palliative sedation is not only an end-of-life option. For folks who have traumatic brain injury or some other major traumatic injury, they've been put into medical comas in order to allow other parts of their body to heal. And studies that have been done with those folks show that after they've come out of palliative sedation, they describe excruciating pain. So it's not a fix for everyone, and it shouldn't be the only option. Another question we get is, aren't people who access medical aid in dying giving up on a cure that might be right around the corner? So, for example, people point to HIV and AIDS as a terminal disease at one point that now can be managed as chronic illness for many years. And while newly discovered cures may work for people in the early stages of an illness, they don't rescue a person who is close to death. Some people may be in the early stages of a disease, and early treatment may work, unlike Brittany Menard, whose early treatment did not work. The fact is, only a person who is dying can, with the advice of loved ones and their physician, decide when the time comes to acknowledge an impending death and to take medication to help them pass peacefully. Many people who obtain the prescription actually don't use it and die naturally. And as I said, it gives them a great deal of comfort. I'll tell you now at this point about another of our supporters who passed last year. His name was Yusuf Cohen, and he described being willing to engage in more immunotherapy treatments that were taking a toll on his body, that the treatment that he was opting for was making him weaker. And he said that if he had the option of getting a prescription for medical aid in dying, he may be willing to enroll in another clinical trial or undergo another form of aggressive treatment, knowing that there was an option. Yusuf and his wife, at the end of his life, flew to Oregon and took up residence there, hoping to take advantage of that state's law, and he passed away before he was able to do that. But I thought his words were important to acknowledge, that people may be willing to undergo more aggressive treatment if they know that there's a way out.
Excellent.
So I want to just stop here with the frequently asked questions and see if there are any questions that you have before we say a few words about how to handle these questions. Are there any questions from the group, Amanda?
No. Okay. Does Compassion and Choices work with End of Life Choices New York?
Yes, they are our partners. They'll be standing with us at our press conference on Monday to announce the reintroduction of the bill. They've been an important partner of ours. We've co-presented at a number of organizations from whom we're seeking endorsements, and we are in contact with them frequently. So yes, we work with them as partners.
Then that was the only question.
Okay, so moving on, I just want to talk a little bit about how to handle hostile questions. Just a word of advice. We spent a lot of time talking to community members over the past 8 months, and there were many times where folks who were absolutely opposed to medical aid in dying would come and ask us questions in a hostile manner or phrased in a hostile way. And what I want to do is encourage you to take your time before answering these questions. And, as I thought about doing this presentation tonight, I thought this is probably good advice for all of us at this point in time with politics in general. So it's a good time for me to remind myself about how to handle this stuff. So my first piece of advice is to take your time before answering. Listen and assume good intent. Hostility is often not the intent of the questioner, although it may have sounded that way. Be diplomatic and stay calm. A good technique is to ask for clarification. When a questioner clarifies the question, sometimes the hostility is removed. The questioner will generally soften as they elaborate on what their concerns are. You can also paraphrase the question back to remove any inflammatory terms and make sure that you understand what's at the core of the question. And lastly, you want to validate the questioner's concern. Usually hostile questions come from people who are frustrated and afraid. Dismissing an individual's concern is always a bad idea. What should we do if someone becomes emotional and loud in their opposition? Some of you who may join us at our press conference on Monday may have the opportunity to put this in practice, because often when we do public activities in Albany, we have people who become emotional and loud in their opposition. What I want to remind folks who work with our campaign is that our campaign is built on compassion and love. We never talk about this campaign as a fight. A lot of people who do legislative work talk about the fight to establish this right or a fight to bring back this funding, and this is not a fight to us. No volunteer or representative of Compassion and Choices should engage in an argument with anyone. The best thing to say to someone who identifies themselves as an opponent is that we respect their opinion. You'd be surprised at how often that can de-escalate a situation. And it's important to say that because we can respect people who oppose medical aid in dying, because the fact is that even when this law passes, no one will be forced to act in a way that is inconsistent with their values and beliefs. And that has become a tagline for me, that when the medical aid in dying passes, nothing will change for people who oppose medical aid in dying. So should I stop and ask for questions, Amanda? It seems like we've been stopping pretty frequently. Maybe there are none, and I should just move on to where people fit into this campaign.
You're on the right track. There's no questions.
Okay. So where do you fit in? Our goal with the New York campaign is to build a movement of individuals, organizations, healthcare professionals, and elected officials who support the right of terminally ill, mentally capable adults to die with dignity. We have established several action teams across the state, and our goal is to have one action team in every single region. We've borrowed this map from New York State, which divides the state into these 11 regions. And right now we have action teams on Long Island, in the lower Hudson Valley. We partner with Death with Dignity Albany, which is an independent organization that's been a strong partner of ours during our campaign. We've got an action team in the North Country, and is that it, Amanda? I'm missing one.
You said Long Island, the lower Hudson Valley, the North Country. New York City, we have a lot of support there. We're just organizing into an action team.
Maybe I didn't miss one. Maybe that's it. We've got a lot of volunteers in Syracuse and a lot of volunteers in Buffalo and also in New York City, but we have not established action teams there yet. And it's a goal of ours to do that. So one of the things we hope comes out of this call and our future activities is that folks realize that there's a place for them in this campaign, and we've got a section on our landing page where you can join a local action team. Those folks are, the leaders of those action teams are conduits to the work of the statewide campaign. And what they do is they share information and activities that can be done on a regional basis, from, tabling at state, tabling at local fairs, to doing in-district meetings with lawmakers. So I encourage people to check out the idea of joining or leading a regional action team.
Corinne, there's a question about Lower Connecticut and if there's an action team there.
Lower Connecticut?
Yeah.
I don't know. I know that there are action teams in Connecticut. I don't know where they are, but we can certainly get back to the caller, to the questioner after this call. Okay, one of the things that we are encouraging supporters to do is what we've been calling a personal influence inventory. All of us have outside activities, be they a pottery class, to the YWCA or the YMCA, a gym membership, membership in a union, membership in a local political club. What we need to do is we need to build the number of organizational endorsements. And we've had a lot of progress over the past few months in gathering organizations that stand behind us in our attempt to authorize medical aid in dying in New York. And we ask you to look at your own connections and see if there's a group that you belong to that would entertain a presentation on medical aid in dying and ultimately endorse the bill. So it's important to our campaign that we build that list. We're also working to enroll more healthcare professionals in this work. We have physician advisors all over the state that we work with in trying to shift their county medical associations. We also work with nurses and the hospice providers. Those healthcare professionals are important messengers for this campaign. Toward that end, we have an Ask Your Doctor flyer that we use, and it's an online tool as well. What we've been doing is asking all of our supporters to take one concrete action, and that is make an appointment with your healthcare provider, whether it's an annual checkup or the next time that you're scheduled to go in, and ask them this question. On our website, and we have flyers that do this as well, you can find out how to have this conversation and how to ask the question, and then report back to us if you find a supportive doctor that we should contact to add his or her name to our list of lawmakers who support us. We'll be circulating that list to lawmakers this year to show all of the individual doctors across the state that support the idea that folks should have access to medical aid to die. It's also important for us to identify these healthcare professionals so that they can be liaisons to their own professional organizations so that we can ask for endorsements there. The next category of people that we have been working on are obviously elected officials. It's the legislature in this state that's going to get us where we need to go. We often get the question, why can't we just do a ballot initiative like they did in Colorado? New York doesn't have that type of a system. A law like this has to be passed by the legislature and signed by the governor. You may say, well, wait a second, I voted on a ballot initiative about casinos. We do have a ballot initiative system. The fact is the governor can choose to put certain questions on the ballot, but we don't have a citizen-driven ballot system here in New York State, so it has to go through the legislature. So what we've been doing is meeting with each elected official one-on-one. This is not the kind of issue that we can guess where someone stands based on their party affiliation or a past vote that they've taken. So we need to sit down, hear their concerns. Many of them have stories about death in their own families. And for those who are supportive, our task is to get them to agree to be co-sponsors of the legislation. We find that many people aren't yet supportive, they still have questions. And so what we do is we figure out what their questions are at the meeting, and then we figure out who has to go in to see them next. If our meeting leads us to believe that they need to hear from a faith leader, or they need to hear from a constituent, or they need to hear from a doctor, put together a team of people like that to send in the next time that they hear from us on medical aid and dying. And for those who don't support us, we encourage them to not be active opponents. They can certainly oppose the bill when it comes up for a vote, but we want to answer enough of their questions so that they're not a vehement supporter that's going to make an inflammatory statement on the floor. And, you know, in the process of doing so, we identify some lawmakers who are capable of changing their minds.
Corinne.
Can I make a comment at this point? Can you hear me?
Sure.
Okay.
Yes.
James Tedisco just replaced Farley in the Schenectady area, and he is not going to be a supporter. He's very Catholic in his orientation. I wrote him a long letter in which I said quite truthfully that I had been raised as a Catholic, but I was strongly supportive of physician aid in dying, and that I would be willing to meet with him to discuss it if it was religious concerns that were keeping him from being supportive. And it might be an advantage if you had people who could say, as members of the Catholic community, they support this.
So I'm going to say a few things in response to that, and I think that's a great example. Senator Tedisco is one of the members that we met with in the past 2 weeks. In fact, he didn't attend the meeting. He was supposed to. It was his staff. And whenever that happens, it's sort of, you can sort of guess why. We've spoken with him informally at the various receptions and meetings that have been happening up here in Albany, and you're absolutely right. He is going to need to hear from constituents. So I don't know your name, but what I'm going to ask you to do is to send one of us an email after this call. We need you for a number of reasons in the way that you
know me. It's Eleanor Arenstein.
Eleanor. I didn't recognize her voice. Thank you. So we'll be in touch with you. Thank you.
Okay.
And what we need to find, we need to find more supporters in the Schenectady area, in his district and in every district where this is going to be a barrier, so that we can make our case. And constituents are the best voices here. So thank you for that question.
Okay.
Corinne, a question. Do we know how the governor feels about medical aid in dying?
I should include that as one of the frequently asked questions, because we get it from everyone. The answer is no. I have met personally with the governor. We've talked to the governor about this issue, and he has not taken a public position. And from my perspective, that is a good thing. Our job right now, and the way that the governor looks at these issues, is that the legislature has to do their job. I'm not saying that we put off worrying about the governor. What we've done, our strategy has been not to press him, because it does us no good right now for him to take a position either for or against, particularly with the way that the relationship between the legislature and the governor is going right now. So what we have done is we have met with everyone around the governor, all of the agency staff and all of the people who advise him on issues like this. We've gotten in front of them. We've shown them what Compassion and Choices does and what we know about this issue and how active we are in the states that have implemented it. And we're confident that when the time comes for him to decide what his position is, he'll be surrounded by people who have access to the best set of facts. So from my perspective, we are perfectly fine with where the governor is on this issue.
All right, and that's it for questions.
Okay, so it's pretty obvious by now that this is not going to be able to happen without your help. This campaign is not a spectator sport, although I do appreciate when people join our Facebook page and follow us. I love interacting with our supporters on our Facebook page, where we update our activities almost daily. To be successful, we're going to all need to get actively involved, and here are some of the ways that you can help us. First is really storytelling. We can't underestimate the power of Brittany Menard's story. When she shared her story with People magazine, legislatures across the country responded. That's why we have a bill in New York that is moving, is because lawmakers heard her story and responded. Personal stories speak to people's hearts and to their shared values. They ground policy in real life. They talk about real people and they humanize the information. Stories help people understand. It's easier for people to grasp the concepts and retain the information about the key provisions in a new law when it's tied to a real person's experience. Our movement has grown exponentially not just because of Brittany, but also because of all of the other storytellers who felt empowered and brave to step forward and tell their own story after she did. Stories depoliticize issues. This is about someone's life, about their death. It's about someone that you're engaging with who'll be helped by changes to the law. And they open doors. In areas where it's difficult to discuss the law or the reform effort, sharing a simple story is a way to open a dialogue. And the fact is, people don't remember facts and figures. They do remember stories. So what's your story? I want to ask all of you on the phone to think about who you are and why you got involved in this movement. Why does access to medical aid in dying matter to you? Were you a witness to a bad death, to a painful death? Do you know someone who was? What are your wishes surrounding how you do and don't want to die? Your own story is more powerful than you may think, and we may very well need you to tell your story to a lawmaker like Senator Tedisco. So aside from storytelling, what are some other volunteer activities that people can engage in? What I can tell you is that whatever your interests are, we need you. This is a grassroots movement. Whatever you like to do, we have a place for you. However much time you have, we can use your help. We can give you the information you need, the training and the materials needed to accomplish any activity. These are just some pictures of people who helped us out at the state fair, who recorded videos for us, who collected signatures at local events, who came to Albany with pictures of their loved ones and told their stories to lawmakers, who stood up in front of crowds and in front of cameras and told their stories, and then came to the Capitol. This picture on the right is actually Amanda, and she was with one of our supporters the day of the Health Committee vote. And we sat and watched the Assembly chamber and then ran to the Health Committee room to watch the vote. And it was important to have people in the room that day. The opponents were there, and we needed to have our supporters there. So there are so many things that you can do. The types of volunteer activities you can engage in are broken into these 4 categories. There are field activities, media, advocacy, and administrative support. And I'll go quickly over each one of these. For field activities, we need people in communities across the state to gather petition signatures. We have a number of ways that we collect petition signatures, and we'd be happy to outfit people if they want to do an action at a mall or at a transit stop in New York City or in somewhere else that you can identify, help us identify where people gather. We have a postcard campaign that we debuted at the State Fair this past summer, where we had over 4,200 postcards to lawmakers signed, and we'll be delivering those postcards throughout the legislative session. We've been promoting our Ask Your Doctor campaign by distributing our trifold flyers that give people the tools about how to have the conversation with their doctors. We've supported volunteers who wanted to host a house party to talk to their friends and neighbors about what the Medical Aid in Dying Act would do, or to host a screening of How to Die in Oregon, or the PBS series Frontline on end-of-life care. We've had supporters staff tables or booths at fairs and conferences across the state. One of the most effective activities that we did last year was when the Health Committee vote was going to happen, we had a phone tree, and some of our very dedicated volunteers called all of our supporters in the districts of members of the Health Committee, and we were able to pull off that Health Committee vote. It was not easy, and it was only due to our efforts. So those of you who took part of that phone banking event, it was tremendously effective, and we're still getting feedback from lawmakers about it. We also need events logistics support. We've been trying to hold events in Ithaca and in Buffalo, and we need people to help us identify venues and help set it up when we come to town with our movie, How to Die in Oregon, or any of the other things that we show, or debates that we host. These are our volunteers from Long Island. They staffed a table at a senior fair this past summer, and they provided information about Compassionate Choices. They told people about the campaign. They got people to sign petitions and postcards, and they found more volunteers. You can also engage in activities around media. You can write letters to the editor if you see a story in your paper about medical aid in dying. You can write a longer opinion piece, and we can help you do that. You can follow us on Twitter and Facebook and participate in discussions online. You can call into radio shows. You can monitor local media for stories and alert us when they happen, because sometimes these papers are not online and we don't get a chance to see the stories. You can read the comments to a story on medical aid in dying and help us find storytellers. Sometimes people share a lot in the comments section of newspapers online about their own stories, and they need to be connected with our campaign. You can be one of those commenters on news stories, and you can change someone's opinion by sharing your own story. And if you've been a trained storyteller with our program, you can be available for press interviews when local media needs to talk to someone. Just another prompt to like us on Facebook, because I think it's fun, and I love to see new supporters. So I hope we get some more after this call.
Corinne,
Another thing you can do is, yeah.
Quick question. Do we have a contact within the Transition Network?
Probably not, because I don't know what the Transition Network is.
So it's an organization for women over 50 in transitions out of working life.
No, but we need to. So whoever asked that question, please get in touch with us after this call. We're always following up on suggestions that people have, and that sounds like a great one. Okay, advocacy activities are really important. We encourage our supporters to visit their elected officials in their district offices or in Albany. Amanda and I are organizing mini lobby days seemingly every week throughout the 6-month legislative session. But what really matters is having people go to lawmakers in their own district offices. Lawmakers are here in Albany 2 to 3 days a week, and the rest of the time they're back in the district. And they want to hear from their constituents. So it's a really good idea to organize a group of 3 or 4 people to attend an in-district meeting and let your lawmaker know how you feel. Writing an old-fashioned letter to your elected official is another way. Oftentimes we ask people to take action online by sending an email, and while those make a difference because lawmakers actually count every communication that comes into their office, I cannot emphasize enough how important it is when people see you when lawmakers see you face to face, or they get a handwritten or just a letter by post. It really does make a big difference. There are often community events where aid in dying is being discussed, and it's fantastic when our supporters show up. One thing Amanda and I have noticed is that when we speak at events, or when one of our supporters is out speaking at an event, our opponents get there early, and they fill up the first 2 rows of every audience. And we are going to reverse that practice this year, because it is very dispiriting for one of our storytellers to be looking out and seeing all opponents in the first 2 rows. So if we've got, terminally ill supporters who are doing public speaking, or any of us, we need to get out there and support them and make sure that we pack the audience and we're up front and center so that they see our faces. We've got yellow T-shirts branded with compassion and choices, and I want to encourage people, if you don't have a yellow T-shirt, let us know. We are going to make sure that people at our lobby day have them, but they're effective for other kinds of community activities as well. We've got a lobby day scheduled for May 9th. All of our energy is going to be put into organizing a fantastic spring lobby day, and we hope that everyone comes and joins us. We had over 100 people registered last year, and we hope to double that number this year. So please plan early for getting to Albany for May 9th for our spring lobby day. I'm going to do a very quick, it's late, I know, and I really appreciate you sticking with us, but I'm going to do a very quick lobbying 101, because many of you are going to be looking at doing visits in your home districts, and I want to give you just these few pieces of advice. First of all, get organized. Do some research on who you're going to visit, what that person's position is on similar issues, and create a team of people to go and visit. We can help you do that. We can share the information that we have about where your lawmaker is, what he said or she said the last time we visited that person, and what they need to hear this time around. The way you request a meeting is calling their district office and asking to talk to the scheduler. You identify yourself as a constituent, and they'll put you down on the schedule. Before going into the meeting, assign different roles. One person is going to be the facilitator, the person who greets the lawmaker, thanks them for taking the meeting, and introduces everyone else. It's good to have a storyteller in the meeting, and it's good to have someone who has a grasp of the facts. And again, we can help you build that team and build the capacity for doing that. Another piece of advice is plan your arrival well. Know where you're going. These district offices are often located in pretty strange places, so you want to map it out before you go. You want to dress conservatively and respectfully, but wearing a campaign t-shirt about this issue is okay. They're used to dealing with that. You don't have to wear a suit to go and visit a lawmaker. Don't be disappointed if you end up meeting with an aide. Oftentimes lawmakers are called off to an important meeting. I know I made a comment before about how Senator Tedisco was not at the meeting. That's not always a sign that they don't care about this issue, and I'm not even saying that about Senator Tedisco. It can be an indication, but oftentimes an aide is the person you're going to be meeting with, and in fact, they're going to know more about any given issue than the lawmaker is. So often it's really good to brief an aide on what the issues are, and they relay the message back to the lawmaker. Make sure you bring materials, which we call leave behinds, so that lawmakers have something to look at after you leave, and we can provide all of those materials as well. Make sure you don't argue with the lawmaker. Your job at that meeting is not to convince him or her, but to provide them with information and reasons to support you. And it's important to listen as much as you talk, because you learn a lot about why a person may have a certain position on this issue. You want to make sure to make an ask at the meeting. If the lawmaker supports you, make sure that you ask them to co-sponsor the bill. If they are a co-sponsor of the bill, you want to ask them to bring along more of their colleagues. You want to say thank you at the end of the meeting, or better yet, to send a thank you card. And lastly, and perhaps equally important to everything else, let us know what you learned at that meeting so we know what to do the next time we get before that lawmaker. So that's your lobbying 101. I'm going to stop here. We only have a few more slides left, but I want to see if people have any questions. Okay. This does not sound very exciting, administrative support, but I have to tell you, we need it and it's effective. The phone calls and participating in a phone tree, helping us organize that is really helpful. We collected 6,000 signatures that we're still entering into a database. We had volunteers from the Capital Region help us with data entry. They got together in groups. We had refreshments. It was lovely, and they helped us do a lot of that data entry. And as I said before, finding presentation venues is another form of administrative support. That's pretty obvious, so finding presentation venues, you know, do a little search of your own network and see where you might be able to help us get in. So my question to you all is, can we count on you? We've got some big goals ahead of us this year. We need to get this bill through the Health Committee again, and that's going to, you know, it's going to be a job like it was last year. And then the bill needs to go through the Assembly Codes Committee, and it has to go to the full Assembly. So our goals are big, and we are going to need your help to succeed this year. So the question is, can we count on you? And I hope the answer is yes. For more information after this call, I want to encourage you to contact either Amanda or me with any questions. These are our phone numbers, and you know how to contact Amanda by email. So please get in touch with us if you have questions, or if you said something on this call and I said we need to hear from you. So I look forward to seeing you all in Albany at some point, or around the state at one of our many events. Please consult our Facebook page and our landing page for a list of current events coming up. Amanda, do you have any final words before we let folks go?
No, there was just one question. Someone is a healthcare provider, so they wanted to know if it's possible to be a volunteer who talks to families looking for help from Compassionate Choices.
That's a question for our end-of-life consultation program, and we'll have to put that person in touch with EOLC.
Perfect. So just either send us an email or give us a call. Both of our phone numbers are up on the screen. Nope, I don't have anything else to say except I thank everyone for joining us tonight, and I look forward to seeing you and working with you in the next few months.
Okay, thank you, and have a good night, everyone. Thank you.